All right. Good morning, everyone, and welcome to our monthly endovascular case from Mount Sinai Hospital here in New York City. I welcome you, Vishal Kapoor, with my partner, Raman Sharma here.
Good morning.
Welcome for another exciting year. Another case is the new academic year, so we're excited to welcome our new fellows, which will be introduced in our live case subsequently. But we have another great, exciting case coming up with Dr. Krishnan and Dr. Guja in the team in the room right now. Before we go live to them, just want to remind our viewers about our New York Endovascular Summit, which is this year is scheduled from September 12th to the 14th. Again, a great 2-day course with a 1-day edition of fellows training as well as the podiatry session training, where you'll get to meet great leaders in the endovascular world from all over in the US, from Europe, from Singapore, and out there. You'll see great live cases, discussions, trials, and all about how to do endovascular stuff in a great but friendly environment. So it's a multi specialty conference, which we'll highly recommend for you to come in, join us. All the details are present on the agenda on the website. If you go to nybebs.org, you can register there, look at the agenda. And of course, we are always available here to answer any questions or concerns you have. But in the meantime, before we do that, we'll just move to the lab. And good morning, Dr. Christian.
Hey, good morning. Good morning, Dr. Kapoor and Dr. Sharma. We've got a great case here today. Can somebody press that button? I just want to reiterate what Dr. Kapoor had said about our conference. You know, Dr. Guja, Sharma, myself, and Dr. Kapoor have been working really hard on putting this together. And I can tell you a couple of things. One is that we have a couple of breakouts prior to the conference on Thursday. These we call it the Mount Sinai Innovations and Imaging Summit. And what's actually happened is that we've been able to, get the support of industry, our industry partners who've been incredible, to set up this summit where we're going to have one summit which is a Philips all-in-on IVUS summit, which is going to talk about the utilization of IVUS in both venous and arterial disease. And so therefore we have slots available for that as well for pre-registration. They're filling up fast, I can tell you that. The other one is we just opened up our Abbott partnered summit, which is about the bioabsorbable and the Aspirin BTK stent. So we have an entire day dedicated to understanding the technology, the data, how it fits into your practice, reimbursement, so on and so forth. And so that is also going to be on the Thursday. And we're also very, very fortunate to really initiate the renal denervation in New York City here. And we've been able to partner with Medtronic to have a renal denervation summit, basically about the spiral system, and really talking about the data, nuances, and obviously all the world experts, for Esprit with Sahil Parikh and Brian DiRobertis, as well as Stephen Coombe. And then obviously with Philips, with Aaron Murphy is going to be there, as well as Kumar Madasari, who's going to run the summit. And then with the Medtronic, they haven't quite decided, but we have our very own Deepak Bhatt, who is the PI of the Spiral series. So we have a lot of excellent people for you to come and learn from. Beyond that, we put together an incredible agenda and of live cases. Our live case sites this year are, aside from Mount Sinai, Dr. Andre Schmidt in Leipzig, followed by Dr. Fadi Saab in Dearborn, Michigan, followed by Dr. Miguel Montero in Arizona, and then of course we have our beloved Dr. Metzger, who always supports us, who is now in Ohio. So I mean, it's a fantastic program. On top of that, Dr. Sharma and Dr. Guja put together an incredible Fellows Summit. And I don't want to steal away Raman's thunder and Karthik's thunder, but I just want to reiterate, just for everybody at home, to understand that if you're young or even a young physician who's out of fellowship, first 2 or 3 years, you can always email Dr. Guja or Dr. Sharma or the team, and we will make exceptions to have you there if you're interested in vascular. Again, it involves cadaver labs, access, Abbott sponsored workshops with Supera, wires, all the simulators, and excellent lectures. And both of them have led the Fellows Case Competition this year. Dr. Guja is the chairman of that. And I can tell you that the Fellows Case Competition for the last few years has been the biggest hit of the conference. So I just want to invite all of you to come. I hope those watching the recorded case will understand that. Anyway, with that long-winded introduction about the conference, I want to introduce our team. Everybody knows goes to my right, next to David, is Dr. Karthik Guja. He's the Director of Endovascular Services at Mount Sinai, South Nassau, integral part of our team here. To his left is Dr. David Song. He's our newest attending. He was our fellow, if you remember, last year, and he graduated. We're thrilled to have him on board. And to Dr. Guja's right is Dr. Harsh Doshi, and Harsh is our endovascular fellow this year from Stony Brook, so we're thrilled to have him. Our team, as always, is incredible. We have Elizabeth Holton, who's our endovascular nurse extraordinaire, trained all of us. And then you have Damien, again, who's been incredible with us. So we have this really, really difficult case, a lot of decision-making, Raman and Vishal. Karthik and I have been talking about it, and we're going to let Harsh present it before we start. Harsh?
Sure. Hello all. So today we'll be dealing with a 67-year-old female who was basically referred to us for bilateral lifestyle limiting claudication progressive to ischemic rest pain, Rutherford Grade 2, Category 4, despite supervised exercise therapy and guideline directed medical therapy. Had a past medical history of diabetes, lipidemia, all the risk factors. In fact, she was recently admitted for DCB and bare metal stenting in the right popliteal artery and drug-eluting stenting in the right anterior tibial artery. Afterwards, she developed, worsening left leg pain at rest. Her history includes being a former smoker, and she's on aspirin, Plavix, and was unable to tolerate Plital as well. So she had a lower extremity duplex that, if you notice, that showed that the popliteal appeared occluded and revascularized with collaterals, as well as significant SFA disease on the left side. So this is the CTA abdominal aorta with bilateral runoff. If you can see it over here.
Does it play? You got to just click it, I think.
Let's see if we can play it.
There you go.
There we go. So as we see, the SFA is going to be occluded, and then you have your infrapopliteal vessels.
So the reason we particularly did this, and you'll see angiographically, it could be a ruptured or a dissected or shut aneurysm. Wanted to make sure that it wasn't, and obviously it turned out not to be. With this percutaneously, we probably might have, but I mean, it's not a great aneurysm case if it was a true aneurysm. So you can see that she has an occluded, popliteal, distal SFA on the left side, and then followed by a patent anterior tibial artery, severely diseased posterior tibial and peroneal arteries. So go ahead next.
Oh, we're almost there. There it is.
Yep.
So there we have the actual occlusion.
Yeah.
Going down.
Now we're coming down.
Bifurcations.
Yep.
Loss or AT. There it is.
Comes back.
That's the AT right there.
PT peroneal. Peroneal is gone. PT faintly visible all the way throughout and all the way down to the foot. I'm glad you didn't put on the 1 millimeter cuts. We would have been here until tomorrow.
Next slide. All right, so I think we'll go to the I think it's important. We're going to go to the angiogram, and I want to show you the angiogram. So Karthik and I got actually David got ultrasound guided access, obviously good access site. So we know the iliacs are fine, so we decided to do a runoff first. And again, this is my horrible runoff, Raman, please don't make fun of me. You can see that the vessel is quite dissected at the level of the pop, really just collaterals. And then we'll take better pictures, I promise. You can see that the AT comes back really robustly at the level of the bifurcation, and there's a rotation of the leg, and then you'll see it in the foot. Then Karthik forced me to take some DSA shots, and you can see here you have a wonderful dorsalis pedis coming down. You can see the occluded peroneal artery there, and the PT is diseased, but does go all the way into the foot. Then we went ahead and did a shot of your occlusion, and you can see here the occluded segment looks very nasty. The PT origin is present briefly. It might be worthwhile to get bilateral access below and come up and reconstruct. We'll see. We'll decide after we cross.
His mic?
Yeah, it's going in and out.
So I did inject into the occlusion. You can see the dissected segment there. So what Karthik and I discussed, and Karthik was actually feeling, right, Karthik, that we could cross from above. But I thought, let's just get access. 15. We'd like to do it in an hour. So Karthik has access from below with, and what wires did you use, Karthik, there?
I just micropuncture, we got it, and then I put a V18 with an overnight trailblazer.
Okay, and I'm up top, guys, with a
So this is interesting. I mean, there's a lot happening so far. A lot of decisions have already been made.
Right.
One that I wanted to definitely talk about, seeing that the PT comes back in the foot.
Mm-hmm.
The ATs are dominant one vessel down. What's your decision process about taking the chance with fixing the PT? Sorry. Let me rephrase that. Accessing the distal PT and using that as your distal access site as you go all the way up to fix retrograde.
Well, what we've done is we went ahead and take a picture from over. We just went ahead and did just a micropuncture access, and what I'm going to do is try to come from above and see whether, and I don't think a micropuncture access would really do anything bad to this DP. So you're right. I mean, we could have gotten the PT, but I do think there is questions about whether we do the trifurcation or not, and we'll decide that. I'm just going to do a little Lomax so Karthik can see what he's doing as well. So we can want to do a little quick roadmap. Let's do a quick roadmap.
So, I asked this question more as like devil's advocate, because me in my practice, I would 100% out of 100 times
go after AT. Yeah.
Right.
So I think AT in the
conversation about saying
So
let's
Raman,
not
we did
touch
speak
the
about it actually.
healthy one.
We did speak about taking the PT access, but we thought that we are not going to introduce a sheath in the AT.
Correct.
Yeah, exactly.
So that's why we
going
took it.
sheathless bareback, I think
And I
really
thought,
does mitigate a lot
and
of
also
the
if
concerns.
we take a PT access, getting back into the AT, I'm assuming we'll be in a dissection plane even from below. So I think I would assume I would prefer to connect the popliteal to the AT
positive
than
on
to
the
the PT
catheter.
because it's a dominant vessel.
Yeah. Sorry, go on.
No, go ahead. No, I think I agree with Raman and Karthik. I mean, in this case, as you look, the AT is the dominant vessel, it's the non-disease segment. So if you just have your microvascular, the microcatheter with the wire in it, I don't think it's going to cause enough trauma unless you really start putting sheets in. But with that caliber, you should not be like that afraid. But of course, you want to make sure the collateral, the PT and the peroneal are coming through the collaterals. So it's not like a barefoot and that's the only real vessel going down. So I think we could still get away with it. And it looks more favorable going from the AT as well.
There we go.
Karthik also made one very, very good point about the fact that the ostium of the AT is 100% not visualized.
Right.
This giant genicular collateral is actually coming off probably between, I don't know, 10 to 15 millimeters away from the actual ostium.
Correct.
You can see it kind of slowly. You can see this
reversed, retrograded
for
the.
There's definitely.
You push
I think you guys are in.
Yeah, well, it looks like we're at least in, but we have to figure out what we need to do here. Let me mag it up for Karthik. I want him to wire from below. Maybe he needs a different wire. But let me just go ahead and mag this up here. Hold on. Apologize. Yeah, it's one of those things that, I failed math, Raman. I don't know what's plus, what's minus here. Okay, ready? You want me to go forward? Yeah, there you go. Pull the wire back here. I'm going to pull the wire back.
Yeah, I think an AT wire is a great wire to give you directionality and see where we are.
Almost.
There it is.
I think you need to make a little curve, maybe.
We're probably in a small different plane or something like that.
Yeah, you're so close right there.
You can give me a wire from above, guys. I'll try from above to get into Karthik's catheter, too. That might be easier. Let me try from above with a command. You give me the same command, David?
Yes, sir.
Yeah. So the idea now, Raman, I think we're obviously going to cross this at some point. The idea now would be, okay, are we going to do what you said, which is reconstruct the trifurcation and do it that way, And I think that's the question that we have to talk about, because I think at some point, we have to figure out what we're going to do.
Yeah.
I think the PT remain occluded, but she's in rest pain for sure. She's been my patient for a long, long time. She felt phenomenal after we opened the right leg, which is really, really bad. And then the left leg has been the one that's really bothered her now. I think I need a new command, guys. This one's
command, please.
I think what will happen is once you cross and you balloon it, you might be surprised to see how the PT and the peroneal also light up. And that could give you a true anatomical description of how the PT is behaving. Sometimes you might just leave it with balloon angioplasty, put in your scaffold if you have to. Nowadays, we have the liberty of using these bioabsorbable scaffolds, and you'll still have good flow down to the PT and the peroneal. So I think after balloon angioplasty, when you have a straight inline flow, you'll have a better idea of how
You need to torque out
your
it,
PT and
you're not
peroneal are behaving. But I think you're almost like there, like you said. I would definitely, in this case, go up front. I'm sure Raman will agree. Have a dual axis, have AT for directionality, rather than just going from the top and then doing it.
look at this.
Oh,
Might get
I
into the
think you're in
PT
the
here.
PT. Yeah, there it
Yeah,
is.
maybe. Yeah. No, perineal.
It's a small-
Peroneal, yeah.
Peroneal, yeah.
Which is actually good for us. Now Karthik can come from above. Give me a torque around this, guys. Let me try to get into the
That's
PT.
interesting. I'll say, I mean, I think with the case
Start
volume
from- you
per
start from
day,
below.
it
Damien.
doesn't make sense to
Damien,
waste all that extra
open
time
second indiflator kit.
trying for the antegrade
Correct.
cross when you know very, very well that you have
don't know.
the
Yep, I see it right
tools
there.
available to you
Right.
to cut 45 minutes, an hour off of the
True.
case with no significant risk to the patient, no change in recovery time, no change in
There you go.
ventilation.
Yeah.
There you go. I think you're in. Hold on.
Potentially,
Let me come up now.
potentially even like more improved, you know,
I'm in a different plane.
Okay.
you know, just like overall. I mean, this
Yeah.
is even less sedation, less.
There you go.
No, I think I agree with him. I mean, especially less use of dye, contrast, radiation, time,
I think you need
everything
a better
matters.
wire, Karthik, that's all.
So I think it's always good to be a little bit more
What
aggressive.
wire do you have? From
They have a command, right?
I have a V18, but I'm going to take a.
Okay, now pull your
Oh,
catheter out.
Firenze.
Pull your wire
Yeah, I
out.
was
now.
gonna say.
Right?
Pull your catheter out.
Yeah.
I mean your wire out.
One second.
I'm sorry. Okay, wire back.
You're in actually, PK.
Okay, I'm in the vessel for sure.
Yeah, you're definitely in the vessel.
Okay, now pull
There
come
it
down
is.
a little bit. Come down a little bit now.
Yeah.
Yeah, like the way it's spinning.
It just
So this is also just one
It's a
one
big
still
vessel.
very important
vessel.
point.
Pull back.
You know, it seems very likely that the antegrade wire has crossed successfully into
There.
this
Nope.
distally axis vessel.
Yeah.
It's important still for everyone watching that if this is a very complex lesion, you're worried about
have to
crossability
Why
of your
do we have to
devices.
I agree.
Still,
Let me come down from above.
As long as
if you
think you're
really,
okay.
yeah, but again,
Show me
the
above.
point is that if you're really worried about
No.
the crossability of lesions, which in this case I'm not particularly worried considering
Okay,
you got an
you can just pull
ultraviolet
that,
catheter into
leave
the
that catheter down.
AT.
Give me a
Still
Spartacore
try
now.
to do the actual
Correct.
externalization.
Actually, I'd like to externalize it because I want to come from
Yeah.
above with another wire. There you go. No. Okay, good, beautiful. Come back.
Oh, but
Push it
now
all the way
just, Now just externalize the other way.
Yeah.
No,
the
no.
question
You know
is,
why? I want to get into the PT
Raman,
now.
Why do we want to externalize? We can just wire it now, right? We know we are
No,
in the
so again, but the question is in terms of like, you know, not necessarily for this case, but in cases where you have dense calcium, very
Yeah.
very tight
yes,
stenotic
Push
lesions,
it,
it gives you a lot of extra
Support.
pushability
Yeah,
and-
definitely.
Push now.
and
Mhm, push.
support.
Yeah.
So now you're saying that
You can walk it out
you
now.
want to go for both AT and PT.
Yeah, I think so.
Yeah.
So why don't you? I'd like to externalize this wire and then come with the same catheter from above. So let Karthik push it out. You can walk that out now. Walk out the. Yeah.
I'm doing it as
Yep. And then what I'm going to do is pull this catheter back and try to wire the PT from above. You need to pull this out now.
Yeah.
Yep. Pull that out carefully without losing your wire. Push the wire, Harsh. Uh-huh.
Okay.
Yeah.
So what I'm going to do now is pull this, as Karthik is going to externalize this wire above top. I'm going to come, because I have an 035 catheter, come from above and try to get into the posterior tibial from above, which we were almost there. Only question is, did I snowplow is what I'm worried about, but we'll figure it out.
Yeah, I mean, I would probably not want to lose. I mean, I know you're not going to lose any purchase or
Okay,
ground, but probably just do
Pushing.
initial balloon and PTA first.
yeah.
Define a little bit more anatomy because remember you have to take a catheter all the way back and then again go back into a subintimal plane or hopefully an intraluminal plane in your case, and then try to re-enter into the
Give me a
PT
new
part of
command.
it.
Command is here.
That or go side by side with an O. and
Yeah.
8.
That's
Or
what I'm doing. I'm going side by side.
Yeah.
It's fine. Let it be there for now. So now what I'm going to do is walk this catheter back as Karthik pushes to about here. Okay, leave it there now. There it is. It's out. So now what we're going to do is come from above with another command wire and try to wire the PT. Now we have full access into the AT. So worst
Yeah.
comes to worst is we're going to do
We have
fine.
straight inline flow into one of the infraplop vessels, which is great.
Yeah, we're going to do at least one. But let me come from above with this wire. Yep. So I'm going to come from above. Hopefully I didn't snowplow too much. If not, we can talk about whether we should bother getting posterior tibial access or not, which would be interesting. Let me just try. It did go somewhere, so let's try here. So I'm coming from above here. So guys, okay, now let's talk about this. So now you've got an occluded popliteal. So Karthik, you tell me, I'm going to push this wire down. This catheter down a little bit. Yep, let me just click that. Right there's a good part.
Yeah, that's good.
So how would you guys treat this? Yep, you're good.
Oh, go, Raman.
Okay. Well, you have a lot. You have a lot of new options as of recently. It kind of depends on what's in your closet. If you have, if all you have are coronary stents and drug-eluting balloons and all that stuff, then you have more of a traditional approach. But now, if you have the scaffolds, that kind of also does change, as far as what your destination therapy is.
Correct.
I think, if the final end, we're not going to talk about the steps to get there. I think the ostium of the AT 100% needs to be stented, whether it's a coronary stent or a scaffold. As of right now, I don't want to say that I'm indifferent to either one. I just believe very strongly that there should be a scaffold.
Right.
Let's go with a roadmap here, guys.
SFA, I think I'll be pretty satisfied with, assuming that your contralateral side shows success with your ICP supera strategy, doing something similar on the left.
Yeah.
The PT, I would probably not be too aggressive with.
Correct.
I would probably just do some. That to me looks like a great atherectomy case with a.
No, it's PT is occluded below.
Device.
You can see it's occluded
Yeah.
below.
The Serenator device. I think that'll be a very, very good treatment strategy for the PT, and just leave that alone. Not be too aggressive with the proximal PT and the TP trunk.
Yeah, this is command. So I think though, if you want to do this, we had to come from below. Looks like because
right. I agree with Raman. I think in this case, the AT into the popliteal definitely needs to have some side of more support rather than just a cutting balloon or more than that. Like you said, nowadays we have scaffold, which is a great therapy for below the knee intervention. I would not be that crazy about PT because already occluded. They were good collaterals. They went in the peritoneal. Okay. Now we'll have a two vessels.
So just fix the AT and put a scaffold in the AT and be done.
Oh, no.
Yeah.
So I'm all for this.
Right.
Fixing the AT. I'm sorry. Fixing the. Yeah. Sorry. I'm all for fixing the PT. I'm all for it.
No, it's not good.
I don't know. I might go the other way. The thing is, for the popliteal segment, I would probably see how subintimal I am. It doesn't look that much. Then just do a DCB and put a scaffold in. After the balloon angioplasty, like I said, the PT and the peritoneal will exactly tell me how the anatomy is, if it lights up, how the ostium is.
I would do the
PTA first. Correct. And then we can actually play exactly.
But
So if my PTA shows up suddenly, now there's more flow to the peritoneal and the posterior tibial, and let's say peritoneal is good and has some ostium, I might cut the peritoneal just to, like you said, do an atherectomy, leave it right there, and put a straight inline from popliteal into the AT and be out for that segment. Rather than trying to do kissing, this, that, it just becomes more complicated.
What is the question?
And also, it's not an ulcer. Remember that. So it's not. It's a rest pain. So how much are we going to achieve with the rest pain and a good dominant AT completing the arch and collaterals going from the peritoneal to the PT versus having an ulcer with straight inline flow? Then I might change my strategy. The ulcer is not the limiting factor here, so I would not be.
For me, I'm gonna have Karthik get quick access here because I think we can easily cross. We have bioabsorbables, obviously technology that I think we can put the scaffold in, and then I think we'll be fine in terms of what we're doing. So in the meantime, what I'm going to do is I'm going to allow Karthik to cross. I'm going to pull this other wire out. I'm going to leave.
So the scaffolds you want to put in the PT or the AT?
Well, the question is, it's going to bring up a lot of interesting questions, right? So I think the ostium of the PT, we can put a scaffold, or the ostium of the AT, we can put a scaffold. I think we have to IVUS size it. So the scaffold size is this whole idea of overlapping scaffolds and bifurcation scaffold has never been attempted.
Correct.
So it'll be very interesting for us to be the first ones to try to attempt it and see what it is. So the idea I like about the scaffold is the fact that it's going to be gone in 3 years. I'm not going to have to deal with it. It's going to be able to support my lesion, and then we're going to be able to go ahead and do it. So but let's cross this first, see how easy the cross is. What I'm concerned about, and I want to tell you both, is that if we cross from below and above and get in two different planes and you create two channels from the popliteal coming in, it may not be worthwhile to scaffold this. So let's figure it out. Let's see how we cross.
So PK, why don't you just do... like me and Raman were talking about, just do balloon angioplasty of the popliteal segment and see how the proximal PT and the peroneal light up. Is there more better blood flow going to the PT peroneal? Because that could define the anatomy a little bit more better and give you a little bit more directionality of how you want to go to.
Okay, leave it right there. We'll leave it right there for now, right? So what I'm going to do right now.
B18, a command. What do you have from the
No,
bottom?
we have the micropuncture for now.
That's a micropuncture wire.
Oh, that's just
Oh, that's from the top. Remember, he fired the.
So I'm just going to leave the wire there. See, I don't like, you see proximal guys, how the wire separates? I don't like that. So right now, that's my little worry here. So what I'm going to do is I'm going to have Karthik just leave the wire there for now, and I'm going to balloon from the AT, yeah, from above. So what I'm going to do is I'm going to pull out my PT wire here, and then I'm going to have Karthik put a clamp on the AT wire down below, which he's already done. And then I'm going to walk this out. I'm going to ask them to give me an IVUS first. Guys, give me an IVUS so we can. You got a clamp on the foot, Karthik?
Yes, I do.
Okay. So 018 IVUS. So we're going to IVUS this, and then we're going to decide. Now, one of the most important things that the audience needs to understand is when you start doing complex cases, IVUS becomes an incredibly important part of our algorithm. So right now, our IVUS use in Mount Sinai is about 80%. We're doing a lot of complex cases, not to say that you guys aren't, but I mean, I think the idea here is that we really want to visualize and understand our sizing. We want to see the impact of true sizing, maximum luminal gain, as well as, stenting of dissected segments to see whether or not, it makes a difference. Yeah. So since I'm blind, I'm going to have Dr. Gujo has much better vision than me, load the IVUS here. And what we're going to do is we're going to go ahead and do this. And I think Raman and Vishal, if Karthik and I see two planes, I think it's better, like you said,
I'll give you another syringe.
Here, via the PT. I think that may be the smart thing to do. So right now,
so
Karthik is loading this IVUS because obviously it's the small part of the wire. And let me wet it for him. And then
so there's a question. Sorry to cut you. There's a question from the audience saying, would you think about, let's say you're not successful in PT right now and you have a straight inline for the AT, would you bring this patient back, stage it for a PT intervention later on through pedal and getting everything right there? Or
answer is no, because I think that if the rest pain is relieved at that stage, we could stop. And that's probably going to be the argument of all the purists in the audience. They're going to say, like I know people who train me would say the same thing, like, why are we bothering? So here we're in the AT. IVUS is live.
Beautiful.
Guys, I'm going to pull back. I'm going to do it on the floor too. So you can see it's a robust AT, right? It's about a 4 millimeter AT.
Can you have an angiogram next to the IVUS, please? Yes, nice. Wow, it's a huge vessel.
It's a huge vessel, so maybe too big for a biabsorbable. And there's the ostium right there, right, very tight. And then here we go. Now, most important is what plane are we in here? Looks like we're pretty good.
Yeah, we're pretty good. Intraluminal. Yeah.
See, we're pretty good, guys. Look at that, PK. Oh my goodness. Raman always says I'm an old man. Look at this. Showing the skills. Look at this. Oh my God. Raman G, you owe me a beer. Look at this.
There's some
Oh, there. He's right there. So I'm bad here.
Just a little bit, in and out. As expected in a CTO. You go in, you go out. But most of the time, you're right. You're intraluminal.
All right, good.
Distally, proximally.
So, Raman, would you now balloon, or would you try to cross from below knowing that you're intraluminal in the distal segment? Balloon. Okay, guys, give us a 3-0 long balloon.
Yeah,
I think it just the balloon for me is not so much. It's more about like
defining,
increasing the
blood flow.
Picture.
Yeah,
that's really all.
Yeah, I agree with Raman. I mean, we just have to improve blood flow to better see what's happening for your PT and peroneal, which PK is interested in. So yeah. So what size do they measure at the ostium of the AT? Because like PK said,
we're going to have our exquisite IVUS team let us know what doctor what is the size of the anterior tibial artery. It looks like it's a 5.
Yeah. Yeah, the reason PK, like for the audience, is asking that is, remember, bioabsorbable scaffolds only come up to 3.75, and you can only dilate 0.5 millimeter more than that, because after that, 4. Yeah. Well, so you can't dilate more than that, otherwise it loses its integrity. So that's where sizing of the IVUS becomes very important, especially if you're starting to use these Aspirin scaffolds.
3.75 can go to 4.25.
Correct, 0.5. That's what I said.
So let's see. I mean, I have,
Yeah, 0.5 is the max you can stretch.
And we can use IVUS because there's a lot of, question about whether either these scaffolds can be seen in IVUS or not. I think we can show the audience
how well
we see it in IVUS.
Yeah.
So I think it'll be a good thing to do. So we're going to load this balloon on this 018 wire if we can, and then we'll go ahead and do it from below. So Karthik is just going to wait as I balloon it. I'm going to ask him to cross. And once he crosses, then we'll have two wires, and we'll work from above, and we'll fix one, and we'll snare the other after we fix it. Of course, this is a very difficult thing to do. I could never do it. So David has loaded the balloon on.
What wire do you have now, Karthik?
I have a command wire. I thought when he balloons, probably a hydrophilic wire will probably.
Yeah, it'll just slide through. Yeah.
The other thing is that you could just do a facilitated balloon re-entry at this point.
Yeah, that's what's going to happen. Once you balloon it, hopefully you'll get a plane and you can just go and
go with a
confianza, pop through. Yep. I would do the same thing. Microcatheter, confianza, pop through the plane when you balloon it. And
so Karthik, feed that wire to me from below. Feed the wire from me below.
No, just keep going, BK.
Yeah, but it's very tight.
In that situation.
No,
yeah, so push the wire from below.
In so long.
It looks fancy, but it's it could be painful. Re-entering through the balloon and going back up. But yeah, so I think that's a good strategy of balloon angioplasty it and then get your PT wire ready. And
you keep pushing.
That's it.
Okay, good. Let's try now.
Wow. Wait, hold on. Your balloon you're putting in through the foot, or are you going from above?
Hold on.
Above. The balloon is coming from
above.
Push a little more. Push a little more from below.
We're almost there, but
give me a little more. Yeah.
Oh, he's probably taking the microcatheter.
It's really tight, guys. The balloon.
I'm sure.
it's probably just, 1 second. Give me 1 second.
Want to wipe it again?
Just the wipe it, yeah.
Okay, we'll wipe it. But don't take it all the way out because it's hard to put in.
No, I'll put it in. Flush the wire.
So with the IVUS being said, so what would your destination therapy be? Would you guys? I think we have to stent the pop, don't you? Or you think no?
Well, I mean, so if you didn't show the pictures of your contralateral where you did your last work, and that was a DCB supera strategy, I presume.
Yes.
Yeah, and if that was successful, you have an example of something that worked. So I would not deviate too far from that plan.
Then we're going to lose external action.
I mean, I agree with Raman. I mean, I'll definitely, based on the sizing, it'll take a good supera size. Remember, we're always concerned when the popliteal is small and you have to use a smaller supera because we know the patency rate goes up, the deployment is not that good. In this case, the vessel size is very robust, so you can have a good deployment of a 5, even as like a 6 or supera if you balloon dilate it well, and that will give us a good long-term patency in this case, which is what we are looking for in treatment of any patient. So I think this is a good landing zone, so quote unquote, where you can use a supera of a good size and get good results. And even the AT is huge, so you, like you said, you can either, if you're against the scaffold part and we think is really mismatch size, then even you can use a coronary stent and then you can go expand it and get a good straight inline flow to the foot. So I think that would not be bad, but DCB with supera.
Wire from above with another wire.
But not the distal SFA measured as what in your IVUS? I don't think we actually saw that.
Yeah, I don't think we just thought we saw the 4.7.
Measurement of the distal SFA.
I saw something measuring it at
4.7. Yeah.
I'm not sure whether that was.
Where were we?
What exactly that was? Go to the beginning of the run, please.
Yeah, so that's your AT.
4.7 is the AT.
No, go to the beginning of the run, please.
Beginning of the run, guys.
Stop measuring stuff. Please go to the
beginning of the run. When beginning of the run.
Stop measuring stuff. Please go to the beginning of the run.
That's fine. Yeah, you're starting from distal. Okay. Yeah, all the way distal.
Yeah, so that's your AT.
Get us a Sparta. We have a Spartacore in the back.
Okay. 5, that's reasonable.
Yeah, so here you could use a scaffold.
But this is your distal.
Yeah, that's the AT.
So now start to slowly come proximal.
The wire up from the bottom.
I want to see the measurement of the last.
Yeah, the distal SFA.
Open portion of the proximal AT. Can he hear me or no?
No,
I got it.
Right? He's in the room.
You pull, PK. It's probably easy for you.
All right, so we're just going to assume some data.
Give me the Spartacore.
I'll do it.
If that proximal AT really did measure at like 4 or 5 or so, I feel more comfortable putting in a coronary stent that we know has good long-term patency in these large vessels in the coronaries, and we're talking about very similar diameters now.
Backload.
Correct.
So I have a question for you guys. Why do you think coronary stent over bioresorbable scaffold?
I think it's the size. I mean, if you really go for size is what the determinant factor in this case. Like you said, 3.75 goes to a 4.25 max, and if the vessel size you're saying is 4.5, 4.7, where he's measuring, then we are really talking about a lot of size mismatch. So in order to have a true good result and giving a real scaffold, I think stent in this case probably would be more better as compared to a bioabsorbable scaffold, in my opinion. I mean, I think it's just
until they made bigger ones.
Exactly. But let's see. I mean, we do a PTA and then we'll see how we do on that
One of
part.
the biggest, I'm sorry about all those wire exchanges. We had a little trouble. And that's to be expected in these cases with difficult wiring and all this stuff. So anyway, I'm just going to walk this out and just push this wire down as far as it'll go, which is fine. And then that's good enough. And then Carter's just going to walk it out. Then we're going to take the O1A balloon, we're going to balloon, and then we'll decide how to come from below. I think, guys, this is what I think. So how many of you believe that in this type of complex lesion, you can get away with the DCB alone?
I don't.
Talking about
balloon.
We're talking about just your popliteal lesion. Are you also including the AT here?
No, popliteal.
Popliteal.
Yeah, going away with just DCB.
Yeah, I'm curious.
I don't know.
If I'm just gonna say, there's if just DCB as a solitary thing, I think the likelihood that your final angiogram, whether you IVUS or not, is going to have you feeling some kind of way before you walk out the room. I think you're going to have a very, very tough time leaving the final result of the post-DCB angiogram in and of itself. Now, this does not mean that it's mandated that the second therapy is actually a stent. You could have a pre-therapy with one of the atherectomies, like the same.
I'll push the wire up from below,
directional.
Get the wire up.
With the atherectomy balloon, just to give it a little bit of a cleaner look.
Let's keep it there. Yep, keep it there for now.
I think that is another option.
Oh, boy.
Okay. Definitely.
Yeah, that's your cap. We'll go up.
I'm pretty sure that your post-DCB angiogram is going to look pretty gnarly.
Yeah,
is he bleeding on the foot?
I would personally not leave it just purely on DCB, even though it might look great. I mean, in this case, with the popliteal CTO going to the AT, I would probably put a Sapera in. I mean, and also thinking about the future implication. Let's say there's ISR, we need a bypass. We still have a very good AT target to do a FEM AT bypass proximally and still get good results because of the vessel size and the non-disease segment there. So, I mean, thinking about not only the present intervention part, but what lies in future in case there is some issues down the lane. I think Supera in here will give great results, especially based on its deployment, less calcification, and a great inflow. I think I would probably just give the best definitive therapy. In this case, we'll do a Supera.
On the IVUS, there's not a lot of
So he's going to need an 018. Yeah, he's going to need an 018 Trailblazer DSA.
Time.
DSA for bucket up.
Through. This is actually a case where the only other legitimate argument that I think you can really push for it, if you want to say you don't want to stent,
it's on DSA.
Inject.
would be to do some form of serration.
Correct, and then DCB. Yeah.
So now we've opened the distal, and there's your cap. So we can reconstruct this, boys.
Yes, definitely.
Let's reconstruct this. This will be fun. Let's go. And be good for her. All right, so we've got 15 minutes to do this. So Dr. Guj and I are going to work here. So the nice thing is we haven't lost our collateralization here. I could try to come from above, but I think at this stage, I think our reaching across from below. But I think we're going to have to come from above and recanalize. It might be worthwhile to come from above here, because if we come from above,
that's pretty nice cap.
I know, it's a beautiful.
You guys
They just balloon.
even use like a Confianza yet.
Yeah, exactly. So give me a
that's what I say.
tip catheter.
It'll pop in.
Yep, give me the
So
vertip
I think
catheter.
that's what me and Raman were talking about, is doing the balloon angioplasty and the pop into the AT, and then suddenly everything lights up and gives you a good directionality. All right, should I go for it or should I just leave it? But in this case, definitely, like you said, if we can give the full benefit to the patient of having a trifurcation, three vessel runoff, this will be an ideal case to do it.
I think it's also important to highlight, the necessity to do a total tibial revascularization is much more. I don't want to make any large generalizations, but is very much more easily defensible and correct if you have ulcers that need to be treated.
Right.
Even more so if you have ulcers in multiple angiozones. How often you're going to be in that situation is a little bit of a different story. But in somebody who, in this patient who is having resting pain, I think the reason why it's justified to go for this PT is because it's just there.
Right.
And it's so close. And if you're able to do so, to reconstruct in a safe way, then you're not burning any bridges for
Don't pull any.
I think I agree with Raman. I mean,
See, the only,
target is right
only
there.
worry, I totally agree with you guys with everything you're saying. The worry from coming from below here that I worry about is that you could actually dissect. There's no wire in this, is there? is that you can actually dissect another plane and then compromise your AT.
Correct.
So it's actually better to try to cross from above here.
Yeah. That is so true.
It's actually better to cross from above, just because you may have another
You'll
plane.
stay in the same plane.
Exactly.
Yeah. I agree with you.
Because I've done cases where I've gotten in trouble from below. Where I've created two planes, and then it's an issue. Let's see.
You don't want to do like a couloir where we have now two things going up in there and go from there.
Do that in distal aorta once.
Yeah, exactly. That's a scary one. Yeah.
Above.
So I think you're right. I mean, it's definitely worth giving it a shot, but it's like, is it a do or die? Probably not. Yeah. But in this case, since the lumen is there, since you already have a wire almost 3/4 the way up, or pretty much right up there, except for the last 10 millimeters, I think it's definitely worth to try to connect the wires and give the patient the full revascularization arm. I mean, again, like Raman talked about, if it was an ulcer, then it's very, very important to give it every shot. In this case, with rest pain, can you get away with it? Yeah, probably, because the anterior tibial is going to fill up your arch.
Getting in from above.
Yeah,
there is clearly an issue.
There's a little bit of a dissection plot probably getting in the way. You have a confianza now?
Yep.
Yeah. I mean, this to me is one of the cases where you give yourself, you put 15
there
minutes
you go.
on the clock.
Yeah.
Okay, now let's see.
That's it.
Walk it back. Okay, now give a little. Nope, I'm getting into that other plane again. See right there?
You crossed early.
No, I'm in the other plane.
No, he's getting into the other plane again.
Oh boy, what is that over there?
Just
pretty.
Oh,
there you go. Now I'm in probably.
No.
Nope. You come from below now. Try to get into my wire.
Yeah. So now I'll give you a below wire, so that'll give you at least a little bit of idea of how far you are.
I think there's an issue going on.
Yeah, it's all venous congestion, I think.
No, it's the plane. It's a plane we created from above, and it's filling up.
I think maybe there's a small venous connection.
Yeah. Venous fistula which forms.
Okay, you can just do a little bit of massage.
This wire is in the vein.
You're in the vein?
No. The wire is in the vein from above.
My wire is in the vein? I don't think
so. No. I think it's just a little bit of venous congestion because of the...
Okay, try the confianza from below. Here's a confianza. Try it from below. No, what are you doing? Oh, shit. No, I got this wire. Yeah, there's a confianza. Give him the confianza.
Yeah. So you tried the command from top, it didn't go through, then you exchanged for a confianza to cross the cap? Is that what you did?
Yeah, that's what we did. I mean, if we can go from below, it would be great. If not, we'll give it another 2 minutes. Yeah. And if not, then we'll just go ahead and...
That's fair,
so you can complete the case live. You guys are at 48:30 right now. Let's say that...
Pain right here?
51.
Completion by 52.
Feels good.
We'll be good.
52, that gives you 8 minutes to finish the case. Should be sufficient.
Remember what Dr. Sharma has told us to finish all cases, not to wait. Not that way. He said not to let it go.
So what wire would you have from below, Karthik?
I have confianza from below.
Okay, that's good.
Huh?
Right there, almost.
Oh, nice.
No.
Yes.
It's not. It's a completely different.
Yeah, it looked a little exciting, but then when it took
I think, I don't know.
No, it's a...
Is that a collateral?
No, it's a plane.
You're totally out?
It's a plane. Yeah, totally out.
Yeah, I agree with you. The way it's behaving.
No, I think
that's where the cap is.
No. It's going the other way. Look at that. So see that venous return now?
Yeah, it's in the vein.
Yeah, it's
But from above, we did not go in the vein, though.
No, you did not.
There you go.
So it's still in the vein.
Yeah. Karthik, you want to pull back your catheter a little bit?
No, that's the cap, Vishal.
Oh, okay.
You can see that you
can see the flesh.
Viewing when you see a lot of extra difficulty crossing, and you engage in an area where you have more challenges wiring, and so that is actually the direction you want to go.
Yeah. You know what? Give me a command from above now. All right, I got an idea. Actually, you know what? Give me a 018. Give me a command.
Give me a...
Sometimes, Karthik, what you could do, which we all try to do most times, is just try to loop the command from below, because that would sometimes form a plane.
Now I don't think you have.
I don't think it's a possibility.
Yeah, now it's probably not.
I think the other problem is that you have a curve on this wire that's suitable for an antegrade cross from top, and maybe not.
So there it deflects off. Yeah, it deflects off right there.
I think it's heavily calcified.
Yeah, she's running parallel to that. Which is very interesting. I mean, it's probably just right at the tip. It just took off into that vein, because you're right. You were into that PT cap for sure, so that's not an issue. It just popped out, I think.
I think it's important I think we've gave it a good attempt. I think as long as we stay within our
Yeah.
previously
I agree.
decided timelines, then if we give it another couple minutes, and if not, then just make our decision final about how we're going to treat this AT and pop.
Yep, I
lesion.
totally agree. One last attempt from above, and then we'll move on. Like I said, the idea would be now is okay. So now IVUS sizing. So anybody would any votes for atherectomy?
I'll go for atherectomy.
So okay, which device would you choose? Silverhawk, which one?
Directional
EXL.
atherectomy. Hawk S. I would go for a S.
Get a Hawk S, guys.
S,
Everybody
yeah.
agrees?
Yeah, I agree. We were intraluminal, there's plaque. We just directional atherectomy with the plane. We PTA, the DCB8 like Raman talked about, and then I would probably just go Supera. I know it looks beautiful, and it is looking great right now, only with PTA into the AT. But
well, I think you got a scaffold ostomy of the AT
Correct.
for sure.
yeah,
So we'll go with a 375 large scaffold into the ostomy of the AT, and then see what
That's a good
happens.
cap.
Let me get
yeah, there is the cap.
Okay.
Perfect.
Push it with the loop if you can.
Yeah, just probably prolapse into that unless we get it.
Give me a torquer.
Yep, talker's coming.
You do have a plane for whatever it might be
It is,
going
it
into. So maybe like
Okay.
PK said, from the
6
top is the better option. That
The
might
problem is I'm
connect.
not able to get
6
enough.
Yeah,
support.
enough
You want to take
support.
that
Huh?
and then put an open 4 on this?
What do you mean Owen foot? See, that's the vein.
Yeah. That's the vein I keep going into too.
Yeah, that's the vein.
But actually, no.
Really?
PK, yeah, I think you're in.
No.
Yeah.
Is it the vein? I don't think so. It's probably another plane.
I think you're in.
Yeah, we're in.
You're right.
Yeah, we're in.
That's not the plane.
Not
yeah.
bad. Okay.
Good.
Let's see. Yeah, we're in. Definitely in.
Are we fluorescing some of these images? I don't
Trying
think I saw
to,
that.
trying to.
Yeah, we're in. Okay, good.
Okay,
We're
very
in
good.
from
Good.
above.
So
All
I'm
right.
going to take.
Yeah, let's walk this out.
So you added
6
50
bench, half one.
seconds.
You just had 12 seconds left, PK.
Yeah. Okay.
Okay.
So now,
Go both out.
So
Now
now,
this
now
is-
we're gonna
this is
balloon
it,
this from
so-
above. So get us an IVUS from above, guys. Actually, give me a 3.0 balloon, 3.040 balloon.
Yeah.
We have.
3.060 actually.
Just kiss it. That's it.
Now, which wire
Both.
is which?
I got 1 second.
Okay, then. So now you balloon the PT, so now it becomes even more interesting.
200.
Is because we have a lot of dissection plane going into the vein, into the PT, popliteal, all the stuff.
Which one?
Now, are we committed to 2 bar scaffolds, one in the AT, which we already decided to stent, or scaffolded, let me rephrase that,
Okay.
and
Okay.
adding a PT component to it where we add another scaffold
Give
to
us
it.
a 3.0
See how it
balloon
does.
now.
Or you can, like you talk about, do atherectomy and see how it goes.
so I would
Yeah.
say if we're committed to the scaffold idea, which
I think we
am
are.
committed to a scaffold. I'm not saying bioresorbable. I'm just calling it the stent or BRS as this category for the tibial vessels. For the AT, now that
Balloon
we
guys,
have
ready to
our
go,
PT
guys.
access,
You guys are taking way too slow. Come on.
coronary stent for the AT,
With the
You-
scaffold.
and do
You
a
love the
scaffold.
coronary stent. Get us a
Only
E.
because of the fact that 375 is just not, no matter what you do, it's going to be needing to be
425.
expanded to a size that's going to be smaller than the vessel diameter. But your PT is clearly a smaller size vessel. So in this case, I think a 375 will do better in the PT TP trunk as opposed to that in the AT, which is clearly a much, much bigger vessel. So if you want to do a coronary stent for the AT and do the scaffold for the TP trunk into the PT, then at least you have some justification with your IVUS that your sizing is going to be appropriate.
Yeah. So I think we just,
Let's go up
So
with the
let's,
balloon here.
yeah, let's go up with the balloon in the PT. See, I think like
Give me a little dive. Make sure I'm in the true PT.
we will, and the thing is now because we have more liberty of using a BVS, I would be probably aggressive because of all
A
the
little
planes
further
and
down.
see how technical with the wires is.
Good.
Put
Go
a
up there.
bioabsorbable scaffold
there.
into the PT, TP trunk into the PT, and then like you said, if the size we can do another IVUS, but if the
687.
size really is a mismatch, we would not go for a scaffold and just go directly for a stent like you talked about,
In
and
the-
then in the AT, yeah.
14.
I think it's just
14.
the pure driving force for an AT's BVS versus
Walk it back.
stenting is
Walk it
size.
back.
Size issue.
All right,
The
DSA
same
now.
reason why
Yep.
before the Megatrons came out, you wouldn't take
Correct.
like a
It's a
375
5 zone.
coronary
DSA.
stent and
Okay,
you're
ready,
Up
guys?
to
Oh,
5
you know.
Even though they say let go, but it doesn't go exactly.
All right,
Pretty good.
there you have a vessel, but there was no vessel. Good. All right, now walk it out slowly.
I would probably just balloon.
Balloon a little further.
Yeah, I would.
Okay, hold on. Rail. You ready?
Yep, rolling.
So now you have 2 externalized
Balloon?
wires from 2 ends.
No.
externalized-
You didn't
No,
externalize the
No,
PT. Okay.
No externalization. Both
Don't.
the wires are out from the pedals.
Yeah, so yeah, that's what I said.
Yes,
Pain
one
there.
wire.
Is there hematoma
From
or
the
something?
AT, one from the
The
PT.
Hematomas have a
AT
lot of
is
pain.
externalized.
Where's the
The
pain in
PT
the
is
foot?
not.
Yeah, yeah.
Where's the pain?
In the foot.
In the foot. Okay. In the back of the foot. The back. This is the problem.
Yeah, I know. I got it.
Both? Okay. Down.
Just give me some blue towels, please.
Yeah, she's bleeding from her access sites because we've now got.
Because we're an
Walk it up.
Which is
walk it
good.
up.
Sign.
Well, yeah, good and bad. But yeah, of course. Yeah.
Good.
I mean,
Yep.
yeah, I mean,
All right, guys.
yeah, you know,
So give me a
hematomas.
Yeah,
Actually, give me an EXL now. I'm just going to atherectomize the PT. Give me an
We've
EXL.
opened up the S and it's ready.
That's fine.
Okay.
Ready.
But I have 2 wires. I can't atherectomize with 2
Yeah,
wires.
you can atherectomize it over 2 hours anyways.
Yeah. So let's not bother right now. We'll do that later. So now I want to do is figure out what we're going to do here. Let's secure our PT. So give me a IVUS. I want to scaffold the PT. Give me an
Correct.
IVUS now.
And then you pull the wire out from the
Yeah,
PT,
pull
it'll
the
be
ET.
patent, and then you just stent across.
IVUS
Yeah,
first.
exactly.
We're not-
That's the
Just
point.
hold off for now.
Wow.
Well, stand
sharp.
across or just
But
almost
meaning AT into.
nearly kiss.
I don't want to kiss now because I don't have to.
Yeah.
It's a very
Well,
favorable anatomy for us.
You can use the wire in the
You don't really.
I mean, because you have
What's the wire? Push the wire in
osteo
the
AT and you
yeah.
have near osteo.
Oh, good. I got it.
yeah, but I don't. It'll be more like a
got
V/T
both. Tell me
stenting
about-
rather than a mini crush. So
you're still
yeah.
going to kiss.
Yeah, you could.
Okay, so
He just wants to skip this step.
So
All right, let's.
IVUS team, we're not going to do mini crush with this device,
Yes.
guys. This is not a mini crush device.
Exactly.
Okay, ready? On. Record.
Yeah, just sizing for the scaffold is what we need for PT.
Yeah.
That's
so
it.
remember, even though Dr. Sharma taught us mini crush, we're not doing mini crush in this. We cannot mini crush the scaffold. It's impossible.
Yeah, we're not.
It's important to get the message home to everybody that the doctors that this is not a coronary. We cannot, and these scaffolds are made of polylactide. So because they're polylactide, you cannot crush it like a regular bifurcation stent.
Right.
So it's very important for the cardiologists at home and the interventionists at home not to think that you can actually do a
100%.
mini crush or a
3-5?
bifurcation stent
Yeah,
technique.
perfect.
I mean, at Sinai, we've always taught bifurcation stent technique. In this situation with
No.
bioabsorbable, we cannot do it. Oh, careful.
So
All right, guys.
3538.
So I
Bio-
think we should do 375. No,
375.
37538.
Was it not a 3-4? What did I see wrong? Okay.
What's the vessel size?
4.5.
3.4.
3.4.
At the proximal TB.
Prox is only 3.4.
3-1, 3-4.
I can't hear you.
Can I have another IVUS? This fell down.
I'm sorry. Okay, so you know what? I like a little bigger. Let's go with the 37538. Let's go with the 37538.
Yeah.
Get 2 of them.
Fine.
You're going to secure the PT into that the cap.
Huh?
Yeah, exactly. Secure the
Well,
PT
don't
in the
we
cap,
really
pull your
have
wire
this?
out, do your atherectomy of the popliteal,
Okay.
DCB scaffold.
37538, please.
Times 2.
So couple of important things about the scaffold for everybody at home. So the scaffold has to be in a particular temperature. So the scaffold has a checkbox for the temperature, and if the arrow is not checked, Habib, can you show everybody at home or Damien the scaffold? Can you concentrate? Can you show us the scaffold, guys, so everybody can see? So it's very important technically that there's a checkbox in the scaffold that is for the temperature. If that checkbox if it's not there, then the problem becomes that the scaffold has raised temperature and therefore is no longer viable to use. So it's very important. Second thing is a couple of things about the scaffold. Vessel prep is incredibly important. You want to be 1-to-1 with your vessel prep. You cannot overdilate the scaffold. Dilating the scaffold will cause fracture of the scaffold and thereby thrombosis or restenosis. Number 3, malapposition of the scaffold is incredibly important. If the scaffold is malapposed, then again, that becomes a problem. So you need to size 1-to-1, and that's why we use IVUS here, as you can see. So Dr. Guja is now doing a shot. We're just going to do the ostium here with the scaffold and into the regular vessel. And so we're now going with the scaffold in. And you can see here,
This
As
would
we
be.
go-
I mean, would you want to get your AT stent ready to go too, so that way you can deploy them both at the same time and really make sure that you preserve the ostium of both of them?
I think you'll be okay.
Well, we do have a 7-French guide, Roman. That's not a bad idea. Do you want to do 2 scaffolds, guys? Kissing scaffolds at the ostium? We could.
Scaffold and coronary stent.
What is the ostium of the AT, guys?
4.9.
4.7.
What is it? 4.9?
4.7.
4.5. Okay, that's too big. So,
Yeah.
well, let's get a coronary scaffold here.
4.538.
4.538.
Yeah, right. Important. The scaffold's temperature has to be. It's like Karthik's coffee's temperature. If it's not right, he's not happy.
Yeah, that's true.
He downloaded an extra software update on his Tesla just to keep his coffee at the perfect temperature.
It gives the morning weather and the coffee
I'm
temperature.
gonna wait for the coronary. Okay, so Karthik does not want to wait for the coronary, and I might agree because it's something new for us.
Fine, you can do it. Yeah. You can quickly go start from the
The
ostium.
vessels are huge. We can separate it. We can do
Okay,
it.
that's a good spot. Ready to go up?
So PK, for learning purposes for deployment of this BVS,
Okay,
is the
go.
same strategy as coronary? They go distal to
Yeah, no,
proximal?
you go 2 atmospheres for 5 seconds. Sorry, 2 atmospheres for 5 seconds. So you count it out: 5, 4, 3, 2, 1. Then another 2 atmospheres. Okay. Another 2 atmospheres for 5 seconds.
Go up to 9 max.
4, 3, 2, 1. Another 2
That's
atmospheres
fellow's
for
job
5
to
seconds.
count the seconds.
All right,
Where's
I'm not
Harsh?
gonna
He's
count
supposed
now.
to count.
Harsh is not counting. He told me he failed math. 5, 4, 3, 2, 1. And then go to nominal now. So we're going to go to nominal, leave it for 30 seconds. The reason you do this is that the polylactate has to actually come off the scaffold, so it has to hydrate. So in this case, I tend to go a little bit higher. I know this is not an Abbott thing. And so we're going to go up to 12 here because me and Karthik are going to do that. So Karthik's already taken the initiative just to go to 12 to make sure that this is fully opposed. And 9 is nominal, which is very important.
Yeah.
So the idea of you can go up to 12, there's nothing wrong. I think the company and all the investigators would agree. The idea here is that you do want to be able to inflate it and oppose it. So you have to wait 30 seconds. So it's like watching paint dry. So you have to inflate it for 30 seconds. So we're going to leave it at 30. And tell me when it's 30, Harsh.
Yes.
Huh?
Is it 30 seconds?
This is actually why
It's 30. Down.
This is actually why I always play music in the
Go up again,
during my cases.
Go up again. 12.
For these long
For the log DCBs.
sitting like silence is
Very good.
So once we do this, it's important. I want all of you to notice the markers, and I think it's very important to see the markers. You see the markers at the end of the balloon? So what I'm going to do is I'm just going to go inside and just do a little soft kiss here, a 6 millimeter kiss. I always do this. It's, I'm an affectionate kind of guy. And you can see here, once you do that, you do the 6-minute kiss here, 6 atmosphere, and out. And then when you pull this out, you want to make sure that you don't move the scaffold.
What is one talking about?
And it's always also incredibly important for you to post dilate this. So give us a 375 postal balloon, guys. Post dilate this. So there's your scaffold looking gorgeous, right?
Oh, beautiful.
No, it's AV fistula.
No, it's AV fistula. Karthik's right.
Yeah.
It's an AV fistula. Okay, give us the postal balloon.
No, I think.
All right, so give us the coronary scaffold then in the meantime. Give us a coronary scaffold.
No, I think it looks like a fistula.
Coronary scaffold, guys.
Take a distal shot. Distal.
Oh my God.
You want a 4-5?
I would put the stent, and then you can.
Yeah,
twist it if
we'll
you
kiss balloon it.
want. I need a 4-5 stent.
He went to grab it.
A 3-5, 3-5 long.
20.
37520. Then we can put the balloon and the stent.
So now, what's the plan for the pop?
The
What's
pop
the
is
verdict here?
now we're going to pull one wire out, then we're going to atherectomize the pop,
DCB.
and then we're going to DCB the pop. Guys, I mean, I'm getting old here, getting a stent. We're one of the busiest stent labs in the country.
Squeeze it out.
Yep.
This one I'm not worried. That one just squeeze it out. This way.
All right, so anyway, they
So I think
finally were
that's-
able to find a stent. Yeah.
Yeah.
Yes.
I got 20 or 3530.
20.
20 is fine.
So we're going to post, and where's my stent?
Zion stent.
Oh,
So I guess the question really, from a technical perspective, is if you plan to do a scaffold supera stent at the popliteal, would because now you're putting a mismatch between a 4.5 AT stent and
4
a
38.
432.
4.538 coronary stent and
You have
a
a
bigger
4 5
supera
38 or
stent,
no?
would you want to put a supera first and then
4.523.
deploy a scaffold
23
to
is
it so you have
enough.
a continuity, or you want to deploy a supera into a 4.5 because then you'll have a narrow neck and then go from back?
Well, the question here is, what do we need to scaffold?
That's,
And I think that's why I want to stay on this case.
I would
because
try
The
to-
supera,
this is, I mean, this is a really important point for everyone watching.
Yeah.
Yeah.
Wait, am I in the right wire?
tunneling of the
Correct.
supera
is not a good.
can be its downfall off the bat.
So that's why PK, so usually what I mean, I don't know, I guess you have to tell us what you do, but personally, you put a supera in
It's not going,
first,
huh?
No, it's going.
and then you
Where
tunnel your coronary stent through it, and you can expand your 4.5 to a 5.5 and just be fine with it. So,
Hold on, hold
but
on.
again, that tunneling
Back up.
or where it
Back up.
actually supera might elongate for the first 5 to 10 millimeters because it's into the AT stent might just be an issue.
That or
So one of the things, guys, I want you to see is that you see this post-tiltation and bifurcation is not very easy.
Get the wire down.
I'm just trying to go with the soft part of the wire. Keep it up there. I'm trying
There.
some, just to jimmy it down. See, it's not going. So I think we might have to go up here. Let's go up here. I'm just going to go up just to try to expand the proximal, right? There we go. We didn't lose wires, so I don't have to go up again to high pressure. Go up to high pressure for me.
I think you
This
did.
is- See, there we go. See that? So it was malopose in that area. So now we're going to go up to, 20. Now we got it at 20. Okay,
Yeah.
good. And where's our distal dots, guys?
Right here.
Right there.
There they are. So we did not
You
come
want
out
to
of
put
it.
the wire down? You want to put the wire down?
Yeah, now I'll put the wire down for sure. Okay, now I'm going to come back up now. I'm going to balloon the proximal. Go up now. Yep.
Yeah.
Are they in Galway making the stent still?
We're going to take the other stent
Oh, yeah.
down. So let's take this.
I'll show you.
Yep, this is the wire for the other stent.
No.
No.
Yeah. So getting back to this pretty
Stenting technique.
critical point here, really.
4 5 23.
Assuming that atherectomy, atherotomy, whatever you want for the
Give me a
pop.
6-0.
Once you do your DCB,
150.
and then now you're planning to see whether what's going to be your final destination afterwards. This idea of taking this pop looks like a
Probably take the
5.5.
5.5,
something
6.
like that.
Yeah.
Atherectomy
Put that
and then-
supera into which vessel, AT or the TP trunk. Okay. That's
So
one
we're going to lose a
question.
little pressure here as we come
Yeah.
down.
Second
It's not
question.
going. It's not going. It's not
B,
fitting.
Do
Doesn't fit.
you spare the
Doesn't
actual
fit. Doesn't
bifurcation?
fit. I'm telling you.
Or
Doesn't
do you
fit.
just do
Pressure.
DCB and spot
It's not
DCB
fitting.
and spot stent wherever you have some of your more pronounced
that it doesn't fit.
dissections?
The guide.
Yeah.
Right here.
Well, I
doesn't
guess,
fit.
I mean, I don't know. In this case, probably do the atherectomy, do the
Wires
DCB.
are intertwined.
No, it's not intertwined. It doesn't fit. Let me take the other one
Yeah.
out. Show me down below.
You have to take your PT wire out, I guess.
No, I'm just taking the PT balloon out
Oh,
because we don't need it really. We're trying.
Right.
Karthik and I were trying to be cute.
A 7 French guide should be able to take
No.
4.5 and a 3 and
6 French guide.
3.75.
no, you can do
Oh.
coronary balloons. Even a 6 French should be able to,
French-
yeah.
No, a 6 French is not going to take a 4.5 and a 3.75.
Ready?
Yeah, not the
Show me
balloons,
above
yeah.
now.
That's too big.
Show me above,
You
brother.
have a 6 French or you have a 7 French?
7 now. Okay, ready? Let's
You
give a
have
little
7,
die here.
Yeah, we always do 7 on
Ready?
this.
Well, listen, guys. This is a biabsorbable, so I don't know the profiles. So it's
Fine.
it's probably a little bit higher.
I would pull back a little bit.
So I'm gonna pull back a
Oh,
little.
yeah.
Almost to the dot. You have the dots be right on top of each other.
Right there?
Yeah, right.
Okay.
Right
Yeah.
there.
Go up.
Watch
Pull
yourself.
back a little bit.
No, but
Hirsch, watch
The
yourself,
synergy?
This is
This is-
this is Zion's. Go up again, a little die.
no,
4.5.
4.5, no.
I'm-
Megatron.
PSA.
Hirsch. Again.
Just, yeah, I agree with Ram. We might,
Yeah.
I would go in a dot.
Back a dot.
Back a
no,
dot.
no, yeah.
I kind of like it, guys. Why do you want to?
Okay.
Yeah, let's just go up.
Floor.
Mm-hmm.
The abluminal surface. 'cause
Yep.
the stent
Mhm.
It's within
Got
the
it.
dots.
Tension.
Yeah, it's inside the
Uh-huh.
dots.
Good. There you go. Now you got it. Go. You got it. 12, 14, 16, 18. Okay, down. Good.
So the reason you didn't want to cross a little bit over into so-called the distal pop or before is just because of the recrossability in the future? Is that what you're concerned about?
Second
Exactly.
later
Give
as
us a
well.
3-5 balloon now. Which is
3-5?
the
4-5.
this is the which is the wire now? I'll leave this in. We're gonna do a kiss now. Which is the wire? Just a 3-5 balloon is fine.
Yeah, 3-5. Take a coronary balloon, so that'll be.
We all have
You have to take the
3-5-30.
wire out. You have to take the balloon out.
Why?
It didn't go, right?
No, but that was a stent. Coronary balloon will go.
He wants to use a
No,
stent
it was
balloon.
no?
No, it was a stent. It was the bioabsorbable. So that's
It was a post balloon.
let's try.
Okay.
Maybe it's small. He's right. Karthik is right. I'm going to be wrong, but I'm hoping that I can kiss this. This is the command, right?
Yeah, take a new coronary balloon, then it'll probably just
That's
fly
what I'm
through.
hoping. That's what I'm hoping for.
Yeah.
3-5-30.
Okay, so now we're just going to start. So we're going to push. Let's see, 3-5-30 is there.
Yep.
So the other thing we just got is left access, keep the access in the bottom, and then come kiss from the bottom. You know, and something we don't believe in. Really, fancy. Above and below, so this way you can.
I think the audio is not working there again.
Yeah, I can't hear you guys.
So we're coming with the coronary
now.
balloon.
Unless everybody was quiet, which is
Again, same
unlikely.
problem. Same problem.
So leave the balloon there. Okay. Take
So
the
what-
stent balloon out.
Yeah,
We'll
we'll-
put a new. No. Leave
Yeah.
the balloon there.
Uh-huh.
Give me a 3-5. One more 3-5.
Walk it up.
3520 NC.
Yeah, I think just take a
Leave this,
deflated
take the
fresh
stent balloon
balloon.
out.
Take it up.
Yeah.
Mm-hmm.
And
Yeah,
now
or-
see if you can push the other one.
See, it's tight. Karthik is feeling it.
Okay, so then
Oh,
Yeah, it's tight.
it's tight.
maybe the wires are intertwined somewhere in the middle. But
Leave the wire there.
They're not intertwined.
no, it's just okay. So use two new coronary, but yeah, it's just probably our use two new 3-5-3-5.
3-5, right?
Oh, wire
That's
came
okay.
back.
Which wire? Oh, the other wire.
80 wire came back.
80 wire is fine.
You know what? Actually, both. Let's take both out.
No, I don't want to
The
take both
external.
out. I don't want to lose the
They're
wires
just
here.
intertwined completely.
Yeah, they're all intertwined. That's the reason.
Who said that?
Yeah, I've been saying that. No, they're not intertwined. Can we replay rewind? All right, good. No, I mean, jokes aside, I think now you'll be just,
Intertwined in each other. We can.
yeah,
Okay,
I'm
now
sure.
you got it. All right, now give me, look at, now we'll unintertwine them because we pulled one wire all the way back, and then we'll see if it goes.
Take this.
All right, hold on to this. Okay, this is the PT wire. Okay,
Yeah.
the AT wire is all the way back. Give me the forcep. Okay, now give me the AT. Show me the AT wire above. Let me pull it all the way into the guide, and we'll go back down. Okay, let me pull it all the way into the guide. Okay, good. Now we're going to go back down. Loop.
Hmm.
All right. No chance of intertwining. Now let's try again.
All right.
So 2 3-5s.
So this is a 3-5.
Now that your intertwining issue is fixed, I would go with
Yeah.
4,
5.
yeah,
And,
3-5.
This is a new.
What is that? A 4-5?
No, this is 3-5.
3-5. Okay.
3-5s.
I think 2 3-5s in
For-
the
yeah,
Occam is
for
all
kissing
we
is
care
fine.
about. Yeah.
Yeah, he wants to kiss
2
and bring it back
3-5s.
up. So
All right. So,
All right.
so in terms of antiplatelet therapy, what are you guys thinking? Would you change?
Oh.
Would anything change with this?
no,
Xarelto.
Xarelto, Plavix
Thank you.
works
so
good.
the only other thing we didn't think about is, would you guys have deployed the Supera first and then deployed the stents into the Supera?
Yeah, that's what we and Raman were talking about, and usually I would do it that way because the tunneling of the Supera into the AT and then trying to expand it just might cause problems. So usually what if we have through and through, which in this case was easy, we would probably deploy a supera, then put your AT stent through it, and we can flare up the like a pot technique. We can flare up the proximal of the AT stent and then oppose it to a supera well, and then hopefully get good results. So that way at least you don't have that angiographic or even visualization physiologically a tunneling right there.
Yeah.
So
That's my only thing.
Yeah, the only other thing is like Raman said, maybe do a DCB and leave it with a good DCB
I
result.
would atherectomize the
Atherectomy and do a good
and then
DCB.
and leave
And then
it.
maybe stent the osteum with the SFA.
See where the actual
Lesion is
requires
a stent.
stenting. If this is a challenge, we're reaching this realm where we're rethinking the idea of how much metal do we leave behind. Is it good? Is it bad? Now we have like the conflicting data saying, hey, actually, like DES is actually not that bad.
Correct.
The whole thing is not that bad, which is kind of the exact opposite of the dogma that we were approaching the last 10, 15 years. So now I'm not saying we put a DES here, but having the plan up front as soon as you go in to say you're going to be putting a scaffold, it does change the entire algorithm quite a bit. I think in this particular case, the tibial ostium have been secured very well in a very, very good fashion. Okay. The inflow equally has to
go
be
up together to 10 guys.
Correct.
If this goes down, then all that work you just did is going to go away.
So that's why my threshold of putting a supera will be very low. I mean, I would probably just not. I know DCB might look very good. Trust me, it will look good if you just based on all the factors we see right now. But I'll still be hesitant not to put a supera in personally. I mean, you cannot be wrong.
That's giving you a 7 millimeter inside the distal pop. So that's pretty big.
That's what I'm saying. In this case, the pop is so good, you can easily go with the 6.0 supera and then deploy it. And that's the reason I didn't want to put a 6.0 and a 4.5. Do the other way around.
10. Okay, say
all
that.
right.
I mean, this is.
It's hard. It's.
I think my first pass on this, I would say, do it the same way that we were doing it so far. Secure the AT PT the way that we did. DCB, I would probably do atherectomy, DCB, and then decide stent supera if I have to.
Okay, DSA, inject.
A few of the atherectomy DCB pictures you take,
correct,
they look really good.
Yeah, that's what I'm saying. So I think we just do a hawk, the directional, and then probably do a DCB, and then you can decide.
Okay, here, which wire is which?
Yeah, I got you.
So I want to IVUS the biabsorbable.
Maybe that part we do offline. No.
All right, we'll do that offline. I agree.
Yeah.
So now give us the DCB now. Give us a 6.0 DCB.
Oh, first atherectomy? No, you did one.
Yeah, I'm going to atherectomy on the
proximal bow.
Proximal pop. So let me pull out the.
I think the PT wire. Yeah, PT wire can come back.
Yep, there's the PT wires out. Okay, PT wire, guys. Here, wire. David?
Yes, sir.
Okay. Now let's take another picture. Here, a little higher, maybe.
Yeah.
Oops, sorry. Okay, ready?
Yes.
Yeah.
Looks great to me.
Yeah, I mean, if your post DCB result looks good, I mean.
Yeah.
Don't super.
You might just stay away from it.
Just PTA.
Yeah, no, I know, but you also had that focal lesion all the way up top where your previous wire buckled as well, so you got to go all the way up over there.
So what's the DCB we're using now?
120,
6.0. Let's do the atherectomy.
120.
So we're going to do the 6.0, 200 or 120?
Yeah.
No. We're going to use
this is an S. We need an EX.
200.
Yeah, I'm going to go long.
Give me a 6.0 200 DCB.
Yeah, 200.
Yeah.
Oh, 150 is fine if we have it.
200 is okay. You can use a whole 200.
Yeah, use the whole. I mean.
Everything is good. You okay? Liz? Pain?
Yeah, probably because she's for the first time feeling her foot.
Okay.
Yeah.
This is S.
This is a Silverhawk X.
Yes.
Mm-hmm.
Yeah, that's fine.
Looks great. Looks beautiful.
Yeah, that's what I'm saying. I'm going to do after we do a DCB, then everybody's going to start having doubts about putting a scaffold in or not in, and you can argue one way or the other.
Yeah.
which I don't expect any flow limiting dissection just based on the PTA. There's nothing. So, and we were intraluminal most of the times, like we
I
saw.
think you have to start a little bit higher because there was that focal lead
Calcium,
right
right.
at the top of the screen.
Off.
Come back a little.
Yep, I agree.
I think this is
Right here.
Right there.
no,
Yeah.
This is it's a really interesting question because it's like you have this idea that you need a scaffold.
Correct.
That you absolutely need it. Now, why? Right? It's just because you don't have any evidence of dense calcium.
Lateral
You
cut.
don't have any evidence of any fibrotic disease.
Right.
You
Needle cutting.
cross with
Yep,
an
yep.
035 catheter up front through a pop CTO. There is this. Then you have conflicting data to say that DES by in and of itself may long term be better than a
Save that.
DCB strategy.
Yep.
Right.
Saving.
And
Balloon?
then the recent paper that came out in JACC saying that
DCB or balloon?
the
DCB.
preemptive DCB with
Where was
with
it to?
scaffold
Well,
stenting versus DCB without scaffold stenting, if that is your algorithm up front, there still is no difference.
Correct.
So it's like, where exactly do we have, where exactly do we have the real clarity up front before reaching our final step to say what is our need for a scaffold? I think that's like
Yeah,
it's
it's
a
very
fluid state.
vital.
Okay.
Fluid state.
No, I agree. So I think we could
a
do is
low
probably do a
35,
DCB. If you want, you can do an IVUS. Remember, IVUS, I won't say over reads, but it really reads from inside. So if you think on IVUS, there's like a floating dissection or something that might impede or get worsened based on your personal experience, then you could probably spot stent that area and just get away with it and not do the whole segment if you don't have to. And in this case, it's not that bad. It's like 150 should be good around.
This focal one right before the two genetic collateral. If you want to say that's the one that's
Spot
for sure
stent.
you're going to stent. I think
That's fair.
That's what I mean.
Scenario.
That's what I mean.
Correct.
You have to stent the prox.
You're not going away. You're not
Prox PT,
dealing with your
but I would not think
tibials,
that's
all that
perineum.
stuff.
Right.
All clean. Now, where would you take your DCB to? Would you take it into the AT?
All the way down.
No.
Just at the distal pop.
Just to the edge. Right?
Yeah, just to the edge.
Yeah. I think that's a
Because you don't want to compromise your flow to the
Problem. You
PT
would have
and the
to stem.
scaffold.
There
You're
it
right.
goes. There it goes.
But the issue is that if you have a distal edge dissection, you
Oh,
at
wide
least
out.
have that proximal
Correct.
cap being covered
Right.
correctly by
Well,
your
or the other thing is, if you really want to be a purist, you could technically use two DCBs. One, you could use a 5.0 DCB for the distal segment into the AT, which is you want to cover all the continuity, and then do a 6 or more proximally. If you want to use two DCBs, I mean, again, that's being a purist. We can talk about the economic standpoint, different story. Or if we like PK is using one long 6.0 and not go all the way in. But there is an option of doing a 5.0 if you really want to go from edge to edge. Yes. So. And the vessel side, like I said, can easily accommodate a 5.0. So the 4.7, and they did it. So I don't think that would be an issue whatsoever. But so he's going to be right at the distal
That's good. Watch it.
palm back. Yeah.
That's pretty good.
No,
That's
that's be on top.
That's pretty good.
No, I don't want to crush the bioabsorbable. Hold on.
I don't think it's
Yeah. See.
It's not like you're going to be by the bioabsorbable. I think you may actually flare the ostium of that AT stent just a little bit more.
No, this is better. I like what Karthik
Yeah,
said.
yeah.
Let's go up here.
This is good.
Just right there. The shoulder of the balloon will probably take care a little bit about
No,
that.
I don't want to crush the
Outside.
bioabsorbable,
Yeah.
guys.
No, we get it. Yeah. We totally get the point.
Pretty good.
Well, technically, we already kissed it. So.
Yeah.
Oh, well, guys, this is a bioabsorbable
Yes.
scaffold, though. Oh, boy.
See that area? Yeah. Right at the distal pop.
Or pull back a
Go
little.
slow. Yeah, I don't like it either. I'm just going to pull back a little. We don't like the way that looks.
Yeah.
Wait a second. Pull back a little bit.
We'll need the super.
Pull back more. That's good.
Okay, go up there.
That's.
No, it will.
Okay.
Just go in.
Right there.
That's good.
Go up now.
Perfect.
Now go up. Now you can dilate it. Now I dilate it aggressively.
It's a big shoulder.
See that portion distally? Doesn't look that. Wow.
Well,
That's still neck.
it's got to be exciting, so don't worry.
I know. Exciting for us, not for you, sweetie.
Well, you should,
It'll go away.
Karthik, you want to go up? It still didn't open up the distal part.
I know I am.
Oh, go slow. Huh? I thought you're counting 5. 1, 2, 3, 4.
there you go. That's it.
Nice.
For her to get used to the pain.
Yeah. No, get it. I mean, just.
You okay?
Yes, I think it's very important, like PK was talking about, staying away from the scaffold, unless we had really IVUSed and marked where the scaffold really ends. In this case, we know it's almost at the ostium, and he kissed it. So we just want to make sure the integrity of the scaffold is there, because that's what the whole idea is, to make sure the long-term patency exists and there's no compromise to the integrity of it, especially after doing so much hard work and getting a true below-the-knee complete revascularization. I think it's important to do that part. So definitely
right now
worth
we're
it.
going to leave it up for 3 minutes. And we're at 48 seconds. So nobody answered the question about how they would anticoagulate this patient.
Oh, yeah, we did.
Yeah, Plavix and Xarelto.
Yeah.
That's what they said.
So no aspirin? You wouldn't do triple therapy?
No.
Yeah, we can do triple. I would. I mean, unless there's any bleeding risk issue, I usually do triple therapy, and then I'll drop the Plavix, and then go from there.
What
And
about
keep
you,
them on
Raman?
aspirin and Xarelto.
Do you ever do triple therapy?
I routinely, for these complex cases, will put them on all three, varying between 1 to 4 weeks of Plavix, and then drop the Plavix.
Yeah, to me, the same thing. I routinely put them on triple therapy when we have multiple stents and DCB, and then I would do the same thing. I feel that, the initial event is going to occur within 1 to 6 weeks. So if you can cover that, and then I think they'll be fine a little bit as we go forward. Karthik, yourself?
I stopped doing triple therapy.
You did. Karthik stopped it. Okay.
If I put Xarelto, I take aspirin out.
Yeah, but I'm talking about initially.
No, initially also. I just stopped it because it's just the bleeding risk is so high with triple therapy now. So
I agree. It is high, but I think when you do a Has-Blood score or whatever the score you want to use.
I've had 2 or 3 patients who had bleeding in the first 2 weeks. As soon as we put Xarelto, aspirin, and Plavix, I just stopped it.
Okay,
Again, so the Voyager study was doing the
Can you scrub out
2
just
point.
room 4?
was doing the aspirin and
Xarelto only.
And the subgroup was looking at Plavix.
Remember, it's a training day.
At the run-in of Plavix.
Correct.
What we saw was that
It's a venogram, though.
up until 28 days,
Let's come down.
concomitant Plavix used as your
just want to
third,
come down because I don't
1
know.
second
Okay.
Antiplatelet.
there was no,
Okay, good.
Bleeding.
in the median use of
Okay,
28
ready? Just
days,
take a little-
there
little
was
puff just
no
to make sure we're not
significant
bleeding anymore.
increase in
Bleeding.
rates of acute stent
Very
thrombosis
good.
or
Beautiful.
ALI.
Okay, good. Walk it out.
Nor was there any improvement
You
in,
love the way it looks.
in outcomes, nor was there any worsening in your bleeding.
It's gone.
Only times you saw increased bleeding was if you had gone beyond the 28 days.
Right.
So, Karthik, I like the idea, it's a new idea to say that you do aspirin, to do Plavix and Xarelto independently, but, as per the Voyager, protocol.
Let's do it again. That looks really good negatively, but let's do it positively.
Yeah, call it a day. Stop right there.
Yeah, I know. I was just telling PK the same thing. Call it a day. Looks beautiful.
It looks really
See,
All right,
that's what we
all
talked
right.
about. The DCU is going to look great.
Let's take a vote. Okay, how many of us, including Dr. Harsh, how many of us want to stent?
Supera.
How many of us don't want to stent?
I mean, I was that area where we.
Yes,
and we-
I
Yeah, you can. I was it. Yeah.
IVUS, I like it. IVUS.
And you know what's going to happen is they're going to see dissection and we're going to stent it. Wait.
IVUS.
No,
Why bother?
I'm
No,
concerned about that area of entry where we
Long-term
initially said-
mechanics.
Guys,
I know, but
okay,
guys,
let-
the IVUS is going to show you exactly
Yeah.
what you are trying to find. So just
But
skip that
no,
step and just go ahead
wait,
and,
but
and
Raman,
just-
in all these stents, right, the inflow is so important.
No,
Correct.
So
That's what we
that's
talked about.
I agree. I agree. This info looks beautiful.
No. But
Frame it in.
to be honest, like me and Raman were talking about, the threshold of stenting will be very low
Ready?
in this case, depending on how the IVUS shows. All right. Anyways, let's go.
Record.
From the AT stent,
Raman, when we initially, I was after we did the
Dissection.
entry,
There. See?
Of course, it's going to show you.
Of course.
right? No. These dissections.
But this
fine.
dissection is not that
It's
crazy,
fine.
and it's very short, very small, not the
Because we
half
were
the
pretty
flap.
much in the lumen most of the time, except that proximal area, distal SFA.
No.
So
All right,
far good. Small
far good.
flap there. Small flap, nothing. So good.
That's all good.
Yeah, there's some.
There.
Yeah.
Flap there.
That's all good. That's
Tiny.
also okay. That's also
Tiny,
okay.
tiny. Remember, these are all drugged, okay?
Correct.
Besides that distal,
Yeah, exactly.
distal one, that's
Yeah.
the only one that was on drugs.
Oh yeah, and there's no real recoil or collapse or non-expanded part. I think that's
I would-
also
I would
important to
leave
look
it
at.
all right. So
People
we're
talk
gonna,
about-
we're gonna leave it. I want to IVUS the scaffold here. Hold on. So I'm gonna
First
try to
time
go into that. I'm
IVUS
gonna
has
put the
ever
wire in. Yeah.
resulted
In not stenting.
Here, I'm gonna get the wire. Oh yeah.
There's
Good
clear data to suggest IVUS increases stenting rate, except for this one.
I just want to IVUS the
I think this
scaffold.
is the only case.
We're gonna
I've
leave
ever
this
seen.
alone. I think I'm going to listen to Raman for the first time in my life, and not that Raman's not right; he's usually right. But the point is, I don't like listening to him, and so there we go. Now Prakash is in trouble. Let's try to get. We're trying to get into the scaffold, Roman G. Okay,
You know what IVUS is really associated with? The dissection.
You're saying don't bother?
Yeah.
I mean,
They can
remember, because you did have.
no, wait, right. Yeah. Remember that the small area, exactly. Don't.
Yeah, right here.
The enemy of good is.
All right, let's just IVUS this to make
Is
sure
IVUS.
this is. Okay, no, it's look at that flap though, boys.
I know, and this is actually, I mean, to be totally honest, this is the only flap that's actually concerning to me out of besides everything else, because this part didn't get as much.
I don't know. I mean, from luminal gain perspective, there's good luminal gain. I mean, if you really want to go
flap,
I don't know. You could go either way.
No, it's the wrong
I would
one.
probably not do anything about it. I think it'll be fine.
All right,
I'll be okay with it.
Let's just take a shot here. Let's make sure. Let me see. Well, I'm going to IVUS it offline and show everybody.
Finally, we're back to the basics of angiography.
Yep.
Yeah.
Coronary.
Just a coronary. Hold on.
It's just 1/4 of a quarter, not much too. I don't see any like.
I see. Oh, it's beautiful.
It's right there.
There's a dissection right there.
There's a bubble.
There's a bubble. That's okay though. I think we need a better wire. Oh, it's not. Now use your IVUS. Go down with the IVUS. Get the IVUS down. IVUS down.
No, I don't want.
The rail to wire. Rail to wire. Rail to wire. Now try to go with it. Now try to advance your wire. There you go. There you go. Now take the IVUS in.
It's going to hit the edge.
See, now I'm certain my ostium is good. So now we're going to go down.
If the IVUS passes,
Yeah. Now I'm certain the ostium is good. Ready? I'm going to pull back, guys. Just come back and show me the ostium.
Yeah, see, you can still see the scaffold as well.
Perfect.
Right there.
We're done. Yeah, we're done,
That's
guys.
good.
Ready?
DSA.
Very, very good.
Let's take
DSA?
one foot shot.
DSA.
I'm curious
Yeah.
to see the difference here.
Ready?
All right, one shot here first just to make sure that that flap is not being supported by our wire. And it looks fantastic.
Beautiful.
We'll follow closely. And then the foot.
Yeah.
All right, let's move that.
There
You
you
know what I've
go.
also
The other way,
started
the other
getting
way.
into the habit of
Uh-huh.
doing?
That's good.
Some of these complex cases, multi-level CTOs, their feet are barely being perfused. When
Ready?
you open all this up,
They get
it's
swollen.
such tense edema,
Yeah.
giving them a pair of compression socks before they actually leave.
Yeah, so I tell them 48 hours, you're going to see a lot of redness, a lot of heat. Beautiful.
Outstanding. Look at that peroneal even coming.
Yeah,
back.
Yeah.
everything
Good
is
for
good.
him.
Nice
Good
job,
for him.
guys. Again, great
Very
job,
good.
everyone. And I think we're done. And so we will follow her closely and let her know how
Yeah.
she's doing. So thanks again,
Super
Vishal. If you
core.
can give all the announcements. And again, thank
Yeah,
you
I
for
think
our
it fell.
team. Thanks,
And
guys.
per close.
Perfect. Awesome. All right, great. Thank you, team. Thank you, Raman, for joining. Everyone, Dr. Christian, Dr. Guja, Dr. Song, great case. Another presentation of how complexity the cases can happen, different viewpoints with excellent results. You can, of course, visit our website, ccclivecases.org, to look at this case and any previous cases in the archive section under the peripheral tab. And again, to remind us about our annual N/EBS conference, go into our website. You'll have the full agenda. We'll be more than happy to see you up there in New York in September. Excellent weather right in Times Square. Good for you to enjoy. And the next live broadcast will be August 28th, which is the fourth Wednesday of next month, 8 o'clock Eastern Standard Time here from New York, Mount Sinai. Till then, have a great day and a month.